Hello, my name is Bruce Levy, and I will be speaking to you about asthma, pathobiology, and assessment. The talk is divided into two major pieces. The first will be about the definition of asthma and pathobiology, and the second about the clinical assessment of asthma and its control. Here are my disclosures. I do have a few consulting relationships, as shown here. I've licensed patents and perform collaborative research with two pharmaceutical companies. We've received grants from the National Institutes of Health, and I have nothing to disclose related to relationships to the tobacco industry. So the definition of asthma. Here's one we like. Asthma is like love. Everyone knows what it is, but no one can agree on its definition. This is by the famous physician Saul Permit. Here's one that's maybe a little more technical. Asthma is a chronic inflammatory disease of the bronchial tubes in which the airways constrict too much and too easily to a variety of environmental stimuli. This captures the definition of asthma, but even more definition and more details have recently been brought to this issue by an expert panel assembled by the National Institutes of Health. Here's the result of the expert deliberation. Asthma is a chronic inflammatory disorder of the airways in which many cells and cellular elements play a role, in particular mast cells, eosinophils, T lymphocytes, macrophages, neutrophils, and epithelial cells. In susceptible individuals, this inflammation causes recurrent episodes of wheezing, breathlessness, chest tightness, and coughing, particularly at night or in the early morning. These episodes are usually associated with widespread but variable airflow obstruction that's often reversible, either spontaneously or with treatment. The inflammation also causes an associated increase in the existing bronchial hyperresponsiveness to a variety of stimuli. Reversibility of airflow limitation may be incomplete in some patients with asthma. So you can see the definition of asthma has progressed to a very detailed description. The NIH is in the process of assembling the next expert panel who will be addressing this definition in the very near future. So the disease burden of asthma is evident, affects all races and ethnicities. It's estimated that 8% of American adults and 10% of American children have current asthma. It's a global problem with as many as 300 million afflicted with asthma. It affects the entire age range from infancy to old age. Interestingly, boys are affected more than girls, but after puberty, women more than men. A dramatic increase has been seen in the prevalence of asthma over the past few decades. Here's an example of a global map for asthma rates. This was done by the GINA group. And one can see here in the green that there are countries that have very high rates of asthma, and then in the yellow, countries that have very low rates of asthma. The gray is where we don't have real standardized data. One thing to note is the global spread of the disease, but another is the very evident geographic variation in asthma rates. Let's talk about risk factors for the development of asthma. Well, most often we see asthma develop in children, in particular those with an allergic predisposition and those who have allergic exposures. But of course, we see this in adults as well. And one particular group to note is those with occupational exposures that may develop something called occupational asthma. In terms of risk factors, it's important to talk about the genetics of asthma. And here's a summation of a good bit of study. The first is that there are single nucleotide polymorphisms associated with asthma in several genes. And this really underlies the notion that asthma is heterogeneous and more of a syndrome than a specific diagnosis. The second is that there are few single nucleotide polymorphisms associated across all ages of the population. And this group of genes with these SNPs affect epithelial cells of the airway with epithelial damage and activation of inflammation signatures. And then the third is that there are genetic loci that are strongly associated with IgE levels, atopy, for example. And interestingly, these are generally not significantly associated with asthma. Here's some data to support that notion. This is the result of a large genome-wide association study published in the New England Journal of Medicine in 2010. You can see that there are over 10,000 cases and 16,000 controls. This is something called a Manhattan plot, and the genes with variants that are above this horizontal line reach statistical significance across the entire genome. And you can see there are many genes that do so. When we look at these genes and the statistical association with either IgE level and asthma, here are those loci linked to asthma. And you can see that the p-values here are very high, at least 10 to the minus 7th or higher. So this is very unlikely to be an association by chance. But the relationships with IgE, these are the loci linked to IgE, shown here, you can see are significant for these 5 genes, but not so for asthma, with one exception, interleukin 13, which we can see is significant for asthma as well as IgE, and also we see that here with the association with IgE and asthma. So atopy and asthma are related, but they appear to have distinct underlying pathogenesis. Here's a graph showing the age of onset of asthma, and you can see the incidence rates per 100,000. And this is largely in the very young. But you can see that even individuals greater than 50 years old can develop new onset asthma. We talked about risk factors. Let's talk about protective factors now. Who's less likely to get asthma? This is perhaps a gene by environment association. And what we've learned over the years in population studies and epidemiology is that smoking, viral infection in early life, having siblings, and farm exposure seems to decrease the likelihood of getting asthma. And here's an example from a farm in Germany where one of the more important studies on the link to farm exposure was performed. In this setting, it's very likely that people living on the farm get exposed to significant amounts of bacteria and fungi. And in that relationship, there's been important work done, published in the New England Journal in 2011. And you can see with life on the farm, there's an increased probability of being exposed to bacteria. But the higher that probability is, and this is in checking bacterial DNA in the mattress dusts in these homes, you can see the lower incidence of asthma. And a similar inverse relationship for fungi in children's room dusts, again for bacteria, but also for fungal culture in this Gabriella study. So to summarize this association, living on a farm increases your exposure to microorganisms, but interestingly decreases atopy and asthma. So the key features of asthma are that the symptoms that patients experience, such as cough, shortness of breath, chest tightness, and wheezing, result from a combination of airway smooth muscle constriction and bronchial inflammation. And you can see this animated relationship between the asthmatic bronchiole and the open normal bronchiole. Here's the infiltration of the airway wall. You can see mucus and inflammation. This is an unfortunate histopathology slide of an asthmatic airway from a patient who succumbed to the condition, provided to me for sharing with you by our pathologist at the Brigham, Robert Padera. And here is now the tissue level demonstration of mucus plugging, the airway mucus metaplasia, mucus cell metaplasia, the increased goblet cells shown here, all the infiltration of inflammatory cells, and then the constriction of the airway smooth muscle in the pink striated material around the airway. So there's mucosal, submucosal, and adventitial edema, kind of the pink coloring here. In addition, the smooth muscle is found in excess mass, and this contractility is so intense you can see it's causing this irregular nature of what was once a smooth inner surface of the airway. There's cellular infiltration, the types of cells we talked about in the definition, eosinophils, T lymphocytes, mast cells. There's excess collagen that's deposited beneath the basement membrane. This leads to what's called airway remodeling. Here's a cross-section of the airway. Here's the airway lumen. Here's the epithelial cells. Here's the basement membrane, inflammatory cells in the submucosa, and here's the smooth muscle down here. And one can see the changes in the airway epithelial cell, the inflammation, the mucocell metaplasia you can see goblet cells with mucus. These red cells are eosinophils. You can see their infiltration into the tissue. This basement membrane should be perhaps the width of a pencil mark. And so the fact that it's more like a Sharpie marker is too thick, and this is associated with disease and disease severity. And again, not extremely well depicted here, but you can see the smooth muscle here. These bundles of smooth muscle are increased and they are hypercontractile. In the airway lumen, we also see mucus such as this, and Kirschmann spirals and Crayola bodies are also found somewhat uniquely in asthma, especially severe asthma. Here are the T lymphocytes. The lymphocyte, this is from the original description of the association of Th2 lymphocytes with asthma by Robinson and colleagues in the New England Journal in 1992. This is an autoradiograph showing positivity for the cytokine interleukin-5 expression, interleukin-4 expression, and GM-CSF expression in these T lymphocytes. This is the positive signal for interleukin-5, and then when you deprive the bronchoalveolar lavage fluid cells of T cells, you can see the signal largely goes away, indicating that this expression is targeted to T cells. This panel of cytokines has been labeled type 2, and so the name Th2, T helper 2 lymphocytes. So antigen it gets processed by antigen-presenting cells via MHC class 2, and there's a naive T cell that gets educated by the antigen-presenting cell to differentiate to a Th2 cell, type 2 cell, rather than a type 1 cell. And this leads to increased expression of these type 2 cytokines, such as interleukin-4, interleukin-5, and also interleukin-13. Interleukin-5 is an important cytokine for promoting eosinophilic inflammation. And IL-4 and IL-13 are important for expression of adhesion molecules to attract inflammatory cells, proliferation of mast cells, synthesis of immunoglobulin E, and for mucin secretion. And these are all hallmarks of the pathology of asthma. So one note to make is that the roles for eosinophils remain controversial. It's not a prerequisite for an asthmatic type inflammatory response, but it is important for some. And with the advent and availability of an anti-IL-5 antibody for human use, we are going to be learning a lot more in the coming years of patients who respond and who don't respond about the role for eosinophils in some patients with asthma. So this concept of T cell responses in asthma has led some to propose a balance between type 1 inflammation that might come from living in a rural environment, being exposed to bacteria and fungi, having a lot of older siblings running around the house, early exposure to daycare, or some infections early in life, leading to type 1 immunity, which in the context of asthma is protective. While others, with the widespread use of antibiotics, a Western lifestyle, living in the city as opposed to the farm, some dietary issues, and sensitized to indoor allergens such as house dust mite and cockroach might favor a type 2 response, a Th2 response, which would predispose to allergic diseases, including asthma. So this balance is probably an oversimplification, as we've learned in more recent investigation that there are other cell types that can influence the immune response, such as regulatory T cells, type 17, so Th17 lymphocytes, and a group of cells called innate lymphoid cells that can release type 2 cytokines in an antigen-independent manner. So T cell responses in asthma are clearly linked to the pathobiology and pathogenesis, but it is slightly more complex, one would say, than a simple type 1, type 2 balance. This slide depicts the potential role for mast cells and smooth muscle cells and their interactions in asthma. So mast cells, shown here, express the receptor for high affinity for immunoglobulin E. And when these receptors are cross-linked, the mast cells release products that are prophlogistic. They can lead to airway smooth muscle constriction, but they can also promote inflammation. And so this is an example of the release of mediators in the presence of IgE, and this elicits B cells to produce more IgE. And these mediators can include the activation of cells for the release of these type 2 cytokines, IL-4 and IL-13. This type of reaction between the mast cells and downstream B cells leads to a feed-forward positive loop where more IgE is produced. There's more cross-linking of the IgE receptor, more release of mediators, and the cycle feeds forward. And this can happen in pathology in an unregulated manner. In human biopsy samples, as shown by Chris Breitling and colleagues in the New England Journal in 2002, these mast cells that you can see here as these red staining cells are embedded in the smooth muscle. So there's direct cell-cell contact, cell-cell interactions between these cells and the release of airway active substances in the presence of IgE and mast cell activation. One of these mediators of airway smooth muscle constriction are leukotrienes. And this pathway was laid down in the late 1900s and illustrated here by Jeffrey Drazen in the New England Journal of Medicine in 1999. In this situation, there are airway cells that are activated, and there's a release of arachidonic acid from the cell membranes by cytosolic phospholipase A2, and in a series of biochemical events, leukotrienes are formed, leukotriene B4, leukotriene C4 in this case, and these are exported from the cell, and they can act to either promote inflammation via leukotriene B4 interactions with leukocytes via the BLT receptor. This is expressed on granulocytes such as eosinophils and neutrophils, as well as on T cells. Or the cysteinyl leukotrienes, leukotriene C4, which fairly rapidly gets converted to leukotriene D4 and ultimately leukotriene E4, can all interact with their specific receptors, shown here, CysLT1, but there are at least two others. And these can promote airway smooth muscle constriction in a very potent manner, as well as eosinophil migration and edema. There are drugs that have been developed to intercept this pathway, to either shut down the entire pathway by inhibition of this important biosynthetic enzyme 5-lipoxygenase, or at the level of the receptor, serving as a receptor-level antagonist and preventing the actions of these leukotrienes. Well, I mentioned via the genetics that the epithelium appears to be a very important signal, especially disordered, dysregulated repair responses in the airway epithelium. So the genetics seem to point to an epithelial defect. And so this has been studied in this context of an epithelial mesenchymal trophic unit in asthma. This EMTU appears to be disordered in functional study with barrier defects, so there's increased permeability, for example, to allergen, failed repair responses to injury and acute inflammation, and then impaired antiviral host defense. Here's some data to link viral infections, especially human rhinovirus, to asthma exacerbations in children and adults. In this interesting study in human rhinovirus challenge, Contoli and colleagues in Nature Medicine showed a very interesting relationship between the ability to generate protective interferon here shown here on the horizontal axis, and a fall in the lung function. Here, the FEV1 decrease from this baseline value. In blue are healthy individuals, and in red are individuals with asthma. And there's an interesting relationship with the more interferon you're able to produce for host defense against viral infections, the less there's a fall in FEV1, in lung function. And you can see that asthmatics fall in this lower end of the spectrum, not producing as much interferon and having a greater decrease in lung function. So airway remodeling results from this repeated injury and infection and inflammation. And this ultimately leads to this epithelial mucocell metaplasia, hypertrophy of the smooth muscle, and as we saw with the basement membrane thickening, enhanced deposition of matrix glycoproteins. When you look at the sputum from asthmatics, especially in the setting of an exacerbation under the microscope, one sees interesting structures. And this is one of them. It's called the Crayola body. And these are clusters of airway epithelial cells that have been sloughed from the mucosal surface from the injury, often from a viral infection. And you can see all these, this is a multicellular cluster of, these are all airway epithelial cells. There's some inflammatory cells that get trapped up in here as well. This is fairly unique. We don't see this in COPD, for example. And then these are these, one might say, beautiful structures called Kirschmann spirals that we see under the microscope. And this is actually inspissated mucus. And this central core, then you can see, traps up inflammatory cells, these small granulocytes, as well as airway epithelial cells. And here they are under the microscope. You can see they stain beautifully. They're very easy to see. They're large structures. And these are almost casts, mucus plugging of the small airways that have been expectorated by the patient. So there's been a good bit of work now to detail the pathways and mediators associated with airway mucosal allergic inflammation, the so-called type 2 inflammation. And there are examples of diverse mediators in asthma that are related to these pathways. One of them is immunoglobulin E, the cytokines, and I've shared with you the type 2 data, but there are other cytokines that are associated with this process. Chemokines and peptides, some of which are shown here. Chitin-like proteins, the leukotrienes, and I've showed you that data as well as gases. And nitric oxide is one of them from inducible nitric oxide synthase, and we'll come back to this in the clinical assessment in just a minute. And this is an illustration of the activation of the epithelial cells by allergens, and then the elicitation of specific mediators that are upstream of this type 2 response shown here, ultimately leading to type 2 cytokines and eosinophils, activation of smooth muscle, mast cells, etc. It's interesting to note that there are now multiple therapeutics targeting individual members of these type 2 pathways. And you'll be hearing more about this from Dr. Elliot Israel in another talk in this series. But there are active drug development efforts related to these cytokines, this chemokine. We already have available anti-IgE. There's anti-IL-5 that's already available, and there will be more to come. Let's switch gears and talk about asthma assessment. And I think the first thing we should cover is establishing the correct diagnosis. And so we look for a characteristic history, a characteristic examination, and specific diagnostic testing. And at the end of the day, asthma is defined by three major phenotypes: episodic airway obstruction, airway hyperresponsiveness, and inflammation of the airways. So let's talk about the history first. So we look for a characteristic history of episodic symptoms, good days and bad days, good times of day, bad times of day. When we think about asthma severity, It's perhaps most convenient to think of it as mild intermittent asthma. So there's a lot of good times and some bad times. Mild persistent asthma, always present, but only to a mild degree. Moderate persistent and severe persistent disease. And we think about daytime symptoms. A mild intermittent asthmatic might have symptoms less than 2 days a week. You can see it increases from there, 3 to 6 days per week, daily, continual. Nighttime symptoms on a monthly basis, less than 2 nights awakening at night with asthma, 3 to 4 nights a month, more than 5 and frequent. Lung function, so normal, greater than 80% by the FEV1, or peak expiratory flow rate. Mild persistent might also be normal, but you can see lung function might decrease with more moderate or severe disease. And then peak expiratory flow rate can be variable as an indicator of airway hyperresponsiveness, not so much in the mild diseases, but more often and more frequent in the moderate and severe persistent forms. Characteristic triggers for symptoms include very common aeroallergens such as furry animals, dust mites, mold, cockroaches, pollens. This is an interesting study by Morgan and colleagues in the New England Journal in 2004, and they did a very aggressive home environmental intervention to decrease patients with asthma's exposure to these types of allergens. And here in the red, in the intervention versus the control, you can see that the maximal number of days with symptoms was decreased with this intervention during the first year, and then when they stopped the intervention and followed up, you can see that this continued forward. But you can also see that while there's a protective benefit, it's not a very large one. And so this alone is not going to be sufficient to control most patients' asthma symptoms. There are other common triggers. Infections, as we mentioned. Medicines, aspirin has an interesting role here. Smoke, exercise, cold weather, because of its drying of the air. Gastroesophageal reflux disease and sinusitis. In terms of characteristic responses to medications, we look for responses in 2 forms. And the first, and most notably for symptom relief, would be bronchodilation, especially to beta-2 adrenergic agonists. So we should see patients' either lung function or symptoms improve with bronchodilator therapy. And then, of course, we try to use anti-inflammatory medications, with steroids currently being the most common used for this purpose. And we should see a decrease in the inflammation in the patients on anti-inflammatory drugs. In terms of the examination, I think the most important thing to cover is wheezing. And we feel that the utility of the physical exam is significant when we ask patients to take a big, deep breath through their open mouth and blow out as hard as they can. And then also with routine tidal breathing, again through their open mouth, deep breathing in and out. A wheeze is a continuous musical sound, and I emphasize musical. It's about 250 milliseconds or longer. It results from the oscillation of imposing airway walls. When one listens, it's important to try to identify whether the wheezing is focal or diffuse. And if it is focal and monophonic, just one tone, we worry about large airway obstruction. Now, this could be from a mucus plug in asthma, but it could also be from an airway tumor, an airway foreign body, and maybe this is a mimic of asthma and not truly asthma. Polyphonic wheezing is generated by small airways, and it's polyphonic, it's musical with multiple tones, and this is because multiple different size airways are involved. Those are expiratory noises, but if you hear inspiratory wheezing, which is sometimes called stridor, this is potentially an emergency, because this results from extrathoracic narrowing of the airway, especially in the larynx. And if you have an 8 millimeter airway, you get short of breath. And you can see that if you only have a 5 millimeter airway, it's an emergency, and patients are often having extremely difficult time breathing. Okay, so let's hear some noises. These are noises from auscultation of the chest, and let's see if we can identify which of these 3 noises are wheezing. Here's the first. All right, here's the second. And the third. Okay. Well, if you said that the first sounded like a normal vesicular sounds from respiration, you were correct. The second was crackles that are heard best on inspiration, sometimes called ralls. And the third was the wheeze, heard best on expiration. Let's just go back for 1 second. We'll play that wheeze again. Expiration, expiration, wheeze, wheeze. Very good. So that's that musical note, a long-lasting note, easy to hear. All right, diagnostic testing is the third point for establishing the correct diagnosis. So pulmonary function testing is generally the way we accomplish this, and we're looking, as shown here in the arrow, at episodic airway or airflow obstruction. So variable expiratory airflow obstruction that varies over time, improves following a bronchodilator, and can be induced sometimes by provocative stimuli, and the most common that's used for this is methacholine. Here's an example of a patient's spirometry, and here's their flow volume loop. It shows an obstructive pattern. So patients take a big deep breath in and they blow out as hard and as fast as they can. They keep going till they can't do anymore, and then they take a deep breath in. And we look by the ATS criteria for at least a 6-second breath. And this is the pattern on exhalation, because it's expiratory airflow. You can see it goes to a peak expiratory flow rate, and if this patient had totally normal airflow, it would connect the dots here between the peak flow, the FEF 50, FEF 75, and FVC. And you can see that there is a coving, a rapid drop after the peak flow, and then ultimately never really reaching the max. This would be the normal range. And then this is the inspiration. So limitation to expiratory flow is characterized by a reduced FEV1, shown here, relatively preserved FVC, although it is slightly low, and then a reduced ratio of the FEV1 to FVC. For bronchodilator testing, we assess lung function before and then 15 minutes after the administration of a bronchodilator, most commonly albuterol. This is looking to document reversible airflow obstruction. Of course, it helps, as we're indicating, with the asthma diagnosis. It also gives a sense to the clinician that there might be an increased likelihood of a response to corticosteroids. It gives patients immediate feedback related to improvement with the use of the medication. It may increase their compliance to the regimen. But one should also notice a caveat that patients may not have an acute response, but it doesn't mean they won't benefit long-term to the bronchodilator therapy. So here's a more concrete example of a woman undergoing bronchodilator testing. Here are her values before, and here are her values afterwards. This is the percent predicted values relative to the population, and here's the change with the bronchodilator. This first value is the forced vital capacity. The second is the forced expiratory volume in 1 second, and here is that ratio. So we start by looking at this ratio, and hers was 0.62. Her percent predicted is 78%, and this is decreased. This is clearly indicative of airflow obstruction. We grade the severity by looking at the FEV1, and here hers was 1.4 liters. This is 57% predicted, So this is decreased as well. It's below 80%. And so this is consistent actually with moderate to severe airflow obstruction. Her FVC, shown here, is 75% of the predicted value. This may also be decreased, but this is not the ideal way to test for restrictive lung disease. When we give her the bronchodilator, what we see is a 16% increase in her FEV1. We can see this on the flow volume loop as the solid line is before the bronchodilator and the dashed line is after the bronchodilator, and you can see that she's moved more air after the bronchodilator. So a positive response to bronchodilator testing is a 12% increase in either the FEV1 or the FVC, and so this means that she had a positive response, and we look for an increase of 200 cc's or more, and she went from 1.4 to 1.63, so that's a 230 cc increase. These values are in liters, and so that would be a positive response. We also use peak expiratory flow rate monitoring. This is, there are many different devices that are available for patients. There's a numeric range, and they can measure these by blowing themselves on their own in their home environment, or in an environment at work, or on the playing field if they're an athlete, to try to gauge how their lung function is doing in environments that are outside the doctor's office. Bronchial challenge testing is used to detect airway hyperreactivity, the second hallmark of asthma. Methacholine is typical, and it's usually administered by a nebulizer in increasing concentrations. And so the spirometry is measured at baseline and then after each concentration of methacholine. The degree of airflow obstruction present after any given concentration is a reflection of the methacholine-induced airway reactivity. Patients with hyperreactive airways will bronchoconstrict at lower concentrations of methacholine. They have twitchy airways. Here's an example of a patient who starts out at 100% of their baseline and receives increasing doses of methacholine, and the follow-up measurement of their FEV1, what you can see is they drop 20% from 100% to 80% of their baseline at a concentration of 6.2 milligrams per ml of methacholine. This is often reported as a provocative concentration, or PC20, for the 20% decline in the FEV1. So a PC20 for methacholine for this patient is 6.2 milligrams per ml. Anything less than 8 milligrams per ml is labeled hyperreactive. Here's an example of a non-reactive patient, and their FEV1 falls some with methacholine, but never really reaches this threshold of a 20% decline, so they're labeled as non-reactive, and that would be the normal response. So the concentration required to induce a 20% fall in the FEV1, the PC20, is reported with bronchial challenge testing, and as I mentioned, less than 8 milligrams per ml is hyperreactive. It's interesting to note that airway hyperreactivity may be present in 15% of normal or healthy individuals without asthma. So this is not the only criteria we use for asthma diagnosis. There are medications commonly used for the treatment of asthma that can affect the results of this test. Corticosteroids for as long as 6 weeks, leukotriene modifiers for 2 days, long-acting bronchodilators for 2 days. And you can see these medications, which are less commonly used nowadays, can affect the responses here for as long as a week. We think about bronchial challenge testing if we have a strong suspicion for asthma, but the spirometry is normal. And when we try a bronchodilator response, we really don't see that 12% increase or 200 cc increase. Sometimes patients present with symptoms like chronic cough or nocturnal cough or episodic chest tightness or unexplained exercise intolerance, recurrent bronchitis, but these are not really present in the doctor's office. So this is when we would think about bronchial challenge testing to see if we can evoke a hyperreactive response. In terms of airway inflammation in asthma, there are many potential biomarkers here. We don't need to do a lung biopsy to establish this. And this is, of course, the third hallmark of the asthma definition, inflammation of the airways. Exhaled nitric oxide, as I mentioned, is produced by an inducible nitric oxide synthase, which is part of a type 2 inflammatory response in the epithelial cells that line the airway. So if this is increased, it would support the notion of type 2 inflammation. Of course, sputum eosinophils might do this, circulating eosinophils and IgE levels might do this, and exhaled breath condensates is used in some locations to look for consistent with airway inflammation in asthma. Exhaled nitric oxide is an adjunct. There are many studies that have looked at this. There's been some variable responses to the trials, so there's no clear consensus yet, but it's an adjunct for symptom measurement and lung function measurement. Perhaps it is a marker of this type 2 inflammation. And the threshold values are at least 15 to 30. Less than 15 is certainly negative. Greater than 30, patients would often be labeled as positive. Certainly greater than 50, patients would be labeled as positive for this exhaled nitric oxide elevation. One note is that it requires appropriate equipment, expertise, and use within a clinical context for reliable assessment of this measurement. So generally speaking, for assessing asthma control, we think of two domains: current impairment and its effect on quality of life and the functional capacity of the individual. And this is by assessment of symptoms, daytime symptoms, nighttime, the frequency, the use of their rescue bronchodilator medication, how frequently they need it, exercise limitation, lung function. So these are the types of domains we look for, the types of measurements we look for, in the current impairment domain. And for future risk, this would be for exacerbations or loss of lung function, we often are asking about courses of oral steroids, a burst of oral steroids and then a taper. How often do patients require that, especially over the last year? So in terms of formal remarks, I'd like to end here with the following take-home messages. Asthma is a heterogeneous syndrome characterized by reversible airflow obstruction, airway hyperreactivity, and airway inflammation with the following features. It usually begins in childhood, but affects all ages, races, ethnicities, and gender. Is strongly linked to allergies and involves allergic type inflammation with the involvement of mast cells, Th2 T cells, and eosinophils. It has intermittent symptoms associated with airways narrowing, and this is reflected in lung function testing by a low FEV1, forced expiratory volume in 1 second, but normal or near normal lung function in between the episodes. Airways are hyper-responsive to both allergens and even non-specific irritants like loud talking or laughing or airway pollution or secondhand smoke. Blood eosinophils, serum IgE, and FeNO, fractional exhalation of nitric oxide, may serve as minimally invasive biomarkers for airway inflammation. Let's talk about a few review questions regarding the content of this lecture. First, environmental factors that predispose to asthma include A, living on farms, B, hepatitis A, C, use of antibiotics, D, older siblings, and E, daycare exposure. So environmental factors that increase the risk of asthma, which of these 5 do so? Well, if you thought the use of antibiotics, you are correct, because living on farms, exposure to microorganisms, including hepatitis A, and environmental ill contacts from older siblings and daycare are all factors that predispose to more type 1, Th1 adaptive immunity, and this seems to decrease the risk for asthma. This is more associated, of course, with type 2 immune responses, as we've mentioned. Note that the use of antibiotics has been associated with changes in host microbiota, and this seems to predispose to type 2 responses. Here's another review question. Airway remodeling in patients with chronic asthma is characterized by A, mucous cell metaplasia, B, smooth muscle atrophy, C, decreased epithelial permeability, and D, thinning of the basement membrane. So which of these are associated in chronic asthma with airway remodeling? Well, the answer here is mucus cell metaplasia. Airway remodeling in chronic asthma leads to increases in goblet cells, this mucus cell metaplasia, smooth muscle hypertrophy, not atrophy, and hyperplasia, increased airway permeability, not decreased, and thickening of the basement membrane, secondary to deposition of extracellular matrix. And here's one more question for you. A 35-year-old mother of two presents with several months of episodic chest tightness. Her symptoms are generally worse in the morning, especially when walking briskly in cold weather. Pulmonary function testing is obtained, and here are the results. The FVC is 2.06 liters, 72% are predicted. The FEV1 is 1.32 liters, 55% are predicted. The ratio of the FEV1 to the FVC is 0.60, 79% are predicted. The peak expiratory flow rate is 3.01, 54% are predicted. And the FEF 2575 is 0.72, or 26% of the predicted value. So how should we interpret these tests? First, A, obstruction due to the reduced peak expiratory flow rate. B, restriction due to the reduced FVC and FEV1. C, obstruction on the basis of the reduced FEF 2575. Or D, obstruction due to the reduced FEV1 to FVC ratio. So one can see that the tests are abnormal, but how should we interpret these? Well, if you said obstruction due to the reduced FEV1 to FVC ratio, this is the best answer. While airflow obstruction is characterized by a decrease in FEV1, peak expiratory flow rate, and the FEF 2575, the most specific finding for obstruction is the reduced FEV1 to FVC ratio. And as I mentioned briefly before, restriction can really only be suggested by spirometry. Other testing is needed to establish this restrictive lung disease. So here are a few references for your perusal on the asthma pathobiology and assessment. I've referred to them along the way during the talk. I also want to give special thanks to Chris Vanta, Jeff Drazen, and Becky Barron for sharing some of the slides I've shared with you today. And once again, here are my disclosures related to consultants, licensed patents, collaborative research, and grant funding. Thank you for your attention.